Hello, everyone, and welcome to Let's Talk. Glad to have you back this week. I am super excited about my guest. We're going to talk about medication-assisted therapy. Before we get going, if this is your first time watching the show, your first time tuning in live, please feel free to come with your questions. We love questions. It's an opportunity to connect to professionals who I know that I don't even have a chance to talk with very often, and who are the best person to answer questions related to the topic at hand. So this week, we're going to be taking a deep dive into medication-assisted therapy, and specifically around opioids, a little bit around methamphetamine with Dr. Michael Miller. Dr. Miller, he's the CEO and medical director of Miller Care Group, which is a non-hospital affiliated group located in Indianapolis. He's a medical director also of 2 detox programs. He actually used to be working as a surgeon before moving into addiction care and medication-assisted therapy. He is known around the area about his pioneering work in methamphetamine addiction and treating that in novel ways. Really excited to have him on the show today. So Dr. Miller, welcome.
Thank you very, very much, Dr. Weiner. It's a pleasure.
Dr. Weiner, I'm going to have to kick you off the show.
Oh my gosh, already the initial faux pas. We got to make a mistake sometime.
That's all right. It happens literally half the time. Well, welcome. Thank you so much for being here. So maybe just to get us started, so going from surgery to addictions is not kind of like the normal path we hear for a lot of physicians. How did this work for you? How did you end up here?
Well, interesting. As a surgeon, I did a lot of wound care and more wound care, and then realized that was pretty much my ideal vocation. And my organization and I at that time, lots of house calls. And we made more and more wound care house calls, and my group still makes a huge amount of house calls, COVID notwithstanding, and we're getting ready to ramp that back up. But when you do wound care house calls, you see people in their natural habitat, lots of pain management, mental and behavioral health issues. So Miller Care Group created additional arms of therapy, mental health, psychiatry, and interestingly, pain management, because homebound patients are homebound, huge majority for pain. And so when you start doing that, the next logical step is, well, boy, a lot of these patients are on a lot of crazy stuff. We need to be looking at the other side of that issue. And so from there, recognizing that pain management was hard to do in the home, we brought that program into the office setting. And the natural follow-on was, you know what? There's a big problem with bad opioid prescribing. More and more of these patients are having these issues, the mental health issues, massive amounts of benzos. And so the logical step was I and my associates need to get trained in this addiction stuff. And so, we basically sought the training and created a very unique program that, at least what we found in our mind, differs dramatically from pretty much any other program out there, outpatient. And then we're lucky enough to find some partners that had a similar mentality, and hence the detox rehabs we're working with. And again, I had a meeting yesterday where we're looking to partner with someone who's getting ready to open a 600-bed detox rehab, long-term rehab facility, and asked us to provide the infrastructure, including substance abuse treatment. So, when you're the first kid on the block with a new idea, people want to see it. And we've been lucky enough to be that little kid.
Yeah, well, and I know later on in the show we're going to talk a little bit about specifically what you're doing that is a little bit different and innovative. Yes. And it's always interesting when you're on the front edge of things that it's easy for people to shoot you down, because in general I think medicine is a pretty conservative field, and it should be. I think that anyone who knows my stance on things like on marijuana, on some drug policy that maybe hasn't been tested as much, or substitutions for things that haven't been tested, know that I very much believe in the process by which we gather data and collect. But at the same time, you do have to develop new things and then collect data, which is exactly what you're doing. So, yes. So I really appreciate what you're up to. So let's pivot now into medication-assisted therapy of the more, we'll call it traditional type when we talk about opioids. So what are you? So when you look at the industry, obviously there's a lot of important elements to it for care, for healing people. Outcomes are much better with Matt than without. What do you see as the best sides of the industry, and what do you feel like the shortcomings are?
The problem is that it's defined as MAT, And the problem is that for some reason people have keep missing the A part. And my experience, 6-7 years of doing addiction and LinkedIn and networking with all these people, the problem is there's a notable absence of the A. Here in Indiana, for example, the overwhelming majority of outpatient programs have no A. They come in, they get their Suboxone or God forbid that horrible M stuff that they tout as a treatment for opioid substance abuse. And the problem is that these patients come in, and it reminds me of the movie Oliver, where you have a long line of children standing there with their bowl waiting for more porridge. In this case, they're waiting for more of the M or Suboxone. There's no attempt at weaning, but more, there's no A. Our experience has been that there's 3 major categories of substance abusers, the smallest being the peer adolescent onset, the peer pressure, drink this, smoke this. We found that's about 5% of the entire SUD population. Next largest category are those that, for better or worse, my colleagues create. The pain pill, benzo, and then suddenly, oh my gosh, I've created an addiction. They find an excuse to kick the patient out and they go to the street. 30%. The biggest category of substance abusers are unquestionably dual diagnosis, untreated mental illness. And if you're not diagnosing anxiety, depression, bipolar, schizophrenia, PTSD, what have you, you stand no chance of helping these people. And the problem is that a few of them offer counseling. And with all due respect, you cannot talk someone out of schizophrenia. You cannot talk someone out of depression. It's a combination of very good mental health, very good psychotropic medications when needed. But I jokingly say the reason we're so successful is we do something very unusual. We make a diagnosis. You need to find out why they're using, and if you do, your chance of success dramatically increase. And that is completely omitted in the overwhelming majority of programs. I don't know how many of our listeners are saying, well, no, it's MAT for a reason, because without the mental health component, you stand little to no chance of success.
Yeah. So we, in the psychosocial side, we generally talk about it as a biopsychosocial problem where there's there's the cravings and the withdrawal, the biological part, but then which is where the medication really steps in the most. But then there's also the psychological side, like you're talking about. Yeah. Why are people doing it? When they get to a place like your clinic, when they get to the Miller Care Group, when they get to me, oftentimes it's not just because they're having fun. It's because they're trying to deal with something really heavy.
Correct.
And so if you take away the substance, which for all of its flaws, of which there are many, in the short term does numb people out, all of a sudden they're still left with that burden they're carrying and no way to deal with it. And it's so much easier then for them to backslide. Correct. So you do have to try to wrap your arms around all of it. And if you're just giving someone like a film or a pill, that's not the whole story.
Because we just had a patient today, and of course, this lady gave us a litany of mental health diagnosis, and of course, coming from this family, psychiatric nurse practitioner, whatever, and it was just a hodgepodge. And of course, no one had looked back at what their predecessors had done. But the basic question we ask is, do you think that you're using your drug of choice, whatever that is, to treat the problems we just discussed? And to the 100% level, it's yes. Yeah, I'm treating myself because what they were doing for me didn't work, or I didn't give it a chance to work, which happens a lot also. But invariably, it's the A is just not happening. It's MT. And in my mind, if you're doing MT, that's also called drug pushing.
Yeah, I mean, it's such an odd. Hey, so I remember when I first was really getting into learning about MAD and moving into the specialty, I remember reading that actually, although I completely agree with you, I think that the MT has a lot of limitations. Technically speaking, it is an ethically okay thing to do under the umbrella of harm reduction, because it's true. Like, at least you're not injecting heroin. Like, you could be, there's a lot of downsides to injecting heroin, and if you're in debt, But yeah, it's missing a huge component, and that brings me to a point that I know we wanted to discuss, which was about financial incentives in this industry, because I think that is an area where I at least feel like they're backwards. So essentially, the way a lot of MAT programs work is they dispense medication, and so you actually make money the higher the dose that somebody is on potentially, but then also the longer you keep them in the clinic, which is kind of counterproductive when you think about healing, right? Like the money from the provider side is more if you kind of keep them sick, or at the very least keep them dependent on you. So how do you feel about those things? And then do you see what do you see as potentially a solution for that?
Well, very true. In our particular program, when they come in, they are told immediately, this is a weaning program. And the beauty of what I've done and the many, many friends and colleagues I've made is our program trends to abstinence. That allows me to not just talk MAT, but since our goal is abstinence and ultimately Vivitrol, which is beautifully acceptable to the pure abstinent community, so I get to live in a couple worlds. And that's the issue is we want abstinence. And yet in our region, one of the largest nationwide corporations, their medical director on a national podium last year or 2 years ago said, we are trained and we believe that people on opioids will never, ever get off. And therefore, our program is based on getting them on a dose of opioids that allows them to function. And I said there could not be a more disingenuous statement or a horrific mentality. Because then if you're not helping them, then what are you doing? And your point well taken, better Suboxone than heroin, but the problem is you're still getting opioid effect. I mean, buprenorphine is a agonist antagonist opioid. We know that. But the problem is you're not helping them. They're still addicted. Now it's just as something prescribed. And we see patients that are on the same dose for 2 years, 3 years, and they're saying to their providers, hey, any chance of me weaning? You know, oh, no, well, and the most common statement, and this one I laugh about, is they're said, we will know when it's time to wean you, as if the angel of God will come from heaven and smack you on the head with the ancient piece of the ark, and then we will have some. It's just ludicrous what doctors tell their patients, and then they come and see us and say, well, they said I might never wean.
Yeah. You know, I remember I was having a conversation at one point with an owner of a medication-assisted therapy clinic who actually just outright said, we were like talking about potentially new interventions or tweaks that we could do. But he actually said, we have them over a barrel. They'll do whatever we want. And that to me was just like heartbreaking to hear that like, because it's true. I mean, like it is true, but at the same time, like, you have to treat that with care, right? That's not something that you just say, well, let's like, we can manipulate this and they'll do it because they have to. Like, I don't know, that kind of, but I think that mentality, there's too much of that right now.
Well, they've changed. I guess they've changed the name of that thing that we pronounce when you graduate medical school. Now it's called the hypocritical oath.
I feel like I should have heard that joke before.
Yeah, but you know, the point is, if you don't have the A, you're not helping anybody. If you're not weaning, you're not. And of course, the key to this, and we had this discussion before, is that the single, in my mind, and basically the single thing that keeps opioid users using opioid is fear of withdrawal. When you talk to them, they say, I would rather do anything than go through withdrawal. And the funniest part is that 2 years ago, the FDA approved a fabulous medication to shut off withdrawal. We have been extensively using it. It is a godsend. It does what it's supposed to do. In its worst case, it dramatically reduces the symptoms of withdrawal. In best case, these people sleep for 48 hours after you start it and they have no withdrawal symptoms. And yet what we hear from colleagues is, well, clonidine seemed to work. And my answer, clonidine works so well, then why are drug addicts not aware of it? Why is no one using it? Why is there still this fear? The second is, well, it's expensive. And my answer is, you know, I can't crunch the numbers on using Suboxone for 2 and 3 and 4 years or the M word, but I can tell you that whatever this costs, it's cheaper. And for those of us that are big proponents of injectable naltrexone, why are you not heading there? Why are you not heading them toward abstinence and letting these people deal with what they want? And I'm amazed because addicts come to us and they say, yes, I want to wean, but I'm terrified of withdrawal. And I hand them this pamphlet and say, in my practice, you are not allowed to withdraw. It is forbidden in my practice, which is an unusual statement telling an addict that they're not allowed to do something that they're conditioned to expect. And it works. It works because they hold these pamphlets to their bosoms like a newborn baby because they can't believe that they've never heard of this and more, that now they have hope that they might accomplish this task and not be punished for it. Because withdrawal, in my mind, is punishment. You're doing something noble and important to save your life, and you're being punished. And so all those arguments, in my mind, pale. They pale. I think it's unethical, immoral, and unprofessional to deny a patient the opportunity to get better. And that's what they're doing. There's no question.
Yeah. Well, and I know that when you first spoke to me and I heard you express that perspective, that really resonated with me. And when we created our medication-assisted therapy clinic at Linden Oaks back when I was directing the program over there, that was really at the heart of what we were feeling as well. Like let's really make a program here where people will leave or have the opportunity to leave rather than just
Right.
stick around forever. But you said something that I think is really important and is something that I'd like for you to expand on a little bit if you're willing. So this
Sure.
idea that like you will not experience withdrawal here, and that withdrawal is a huge threat. And I completely agree with you that the avoiding withdrawal really is like the centerpiece of someone's life when they're deep in an addiction. It's not about getting high. It's not about pleasure. It's largely just about avoiding a crash and
Correct.
feeling like you're scrambling and scrambling and scrambling to do that. So you're a big proponent of potentially a different sort of technique where you get someone, not only do they not have withdrawal, but you actually get them off of what they're on very quickly and onto something like, say, naltrexone, which you mentioned before. What is your technique, and how does it differ from the standard approach?
And again, I jokingly said earlier, and it's actually, we make a diagnosis. So we sit down and we talk to them and we find out which of the three categories are you? Are you a pain patient? Because if they have pain, you got to treat the pain without controlled substances. So we do that. And I can tell you that that's very dissonant, because a patient that was on narcotics for pain, when you take away their Suboxone, they will have pain. So if you don't treat the pain, you've not solved the problem. And again, 20, 30% of opioid addicts and arguably SUD people have that. So we concentrate on that. We want to know how you got on, why you got on, what your use is, what your use parameters. Why do you think you continue to use? So we make that diagnosis. The next step then is we identify an appropriate dose of Suboxone twice a day. Our goal is, and our parameter for change is cravings. Now, cravings, I think, is an objectively subjective finding. There's no way to measure cravings, but, people know when they're craving. It's that overwhelming compulsion to seek that drug. So we tell them, we want to shut off your cravings. So we will put you on a dose of Suboxone that is suitable to shut off your cravings. Number two, if you have mental health issues, you will see my psychiatric team and you will see my mental health team. We will put you on this for a period of 4 weeks or whatever it takes till you're not craving. Once you're not craving, 4 weeks of no craving, you go down 2 milligrams. And we see them weekly. Now, one of the treatments we've got is, and that week is either me or my associates, the addiction team, mental health or psychiatry every week. The other thing we have is you can't cheat us, because we are using a new technique where we get their DNA from a cheek swab when they come in. So we don't have to watch them pee, because when you submit that urine specimen, the cup screening gives us the initial yes or no, but our gas chromatography DNA within the next couple of days lets us know whether we have your urine or Fluffy the cat's urine and what's in it. And then from there, we then react. If you're good and clean, you then get the rest of your, and of course, over time, patients get the benefit of the doubt. Someone that's gone 16, 14, 12, 10, 8, 6, we are still getting weekly urines, but they get the benefit of the doubt if they're doing that. But the program is weekly. No one gets more than 7 days of their treatment drug, in this case, Suboxone, and we wean every 4 weeks or thereabouts. Now, the problem is, as I say, sometimes life happens. The cat doesn't eat all its litter. Oprah gets canceled for the day. There's major life stress. And so they come in and they're not ready to go down. That's okay. We say, well, if not this week, you think next week. And if they say yes, we now have an emotional handcuff, because next week they know, come heck or high water, they're going down. So while we ideally would like that 2 milligram wean, it may take a couple months longer. But those that want it, they get weaned, they come off. That drug Lucimir is used for 9 to 14 days without withdrawal, and then on to the Vivitrol, which I call the bulletproof vest. But they continue the mental health and they continue the psychiatry, because without the A, you're just pushing pills.
Yeah, well, so I a couple of things really struck me as something that we should underscore and maybe even talk a little bit more about for any viewers who are doing this work themselves. So the first is this question of, it sounds like you aggressively frame this, like in your words, as a weaning program.
Correct.
And I think that is the missing link, is this idea that this is a means to an end, not for most people has to be an end in itself. It can be, and I think that there are some folks where maybe they do not function well without Matt, but naltrexone, of course, right? That can be a place where you could sit for a long time and you're not having an opioid effect. But I think that expectation setting at the outset is huge right now on the opioid spectrum, regardless of where you are. This was even something that we were talking about back in the front end of opioid addiction with surgeons, where we would say, so you're getting these pills. Here's how I expect you to taper and eventually make it down to NSAIDs and acetaminophen. We can adjust if we need to. And then when you're done, here's how you dispose of them, keep them off your shelf, but really setting very clear expectations for pain, for disposal, for all of that.
Yes.
You are very clear from the beginning. We don't want you on Suboxone. You won't be on Suboxone forever with me. That's just not what we're up to here.
Yeah. If this is not your goal, then this is not the program for you. We're willing to upfront say, if you feel that you won't ever get off, then you need to go somewhere else. When you decide, we're here, we're ready.
Yeah. Well, so that was one. And the second was what you're talking about with the urine drug screens. And I have to admit, I am in the addiction world. I had not heard of DNA matching on drug screens, that was something that was available. But oh my goodness, that would be so useful in terms of people providing alternative urine or get a friend to bring it in. I mean, there's all of the shenanigans that go on with that when people are really deep in an addiction. And this just completely cuts all that off, because either it's your DNA or it's not. Can you tell us a little bit more about that? Are there like bunches of vendors who do that work? What should we know about it?
I'm happy to give the name to anybody. I don't want to be accused of, commercializing. I have no vested interest in the company. If you give me permission, I'll say their name, but this is
not a CME talk.
Okay,
you can say whatever you want.
Genetox. We use Genetox. They came to us and presented this, and it was like, this is a no-brainer. And in our expanding program, we've said this guarantees to as close to 100% as you can. And our patients are told up front, I want you to understand, we recognize that you're going to try and beat us. It's not going to happen. We have your DNA. So you are welcome to try. The problem is, if you try, then with a reasonable degree of medical certainty, I'm going to kick you to the curb. Now, interestingly, on that topic, we don't discharge a lot of patients. They may leave us, but it takes a lot to get kicked out of my program. Being abusive is... But even if you continue to fail, then you get what I affectionately call the 2-week break. Well, I say, look, and actually I start that conversation, you'll like this, by asking them if they have funeral arrangements made. I say, do you have funeral arrangements made? And they say, why? And I hand them the slip and I say, because you're going to die. Anybody that's got this much in their urine, you got meth, heroin, or the other thing is I ask them what they bought from the dealer, what they think they bought. Well, I bought heroin, and you're looking at a urine that has benzodiazepines, fentanyl, cocaine, and meth. And I say, you know what? I don't understand how you guys can let someone cheat you knowingly. But the point is that we know what's in your urine, and we tell them. So if they mess up, then they're told you need to take a 2-week break. You need to somehow keep yourself alive, because obviously I can't advocate buying bupe on the street or whatever. You come back in 2 weeks if you decide you're serious, and we'll do that. Because in good conscience and ethically, I can't kick someone out unless they've been abusive, unless they failed, but we have patients who come back after 3 or 4 months and say, I changed my mind. I want the help. I've thought about it. I can't do this anymore. I think to do otherwise is not right, because we know there's plenty of clinics that kick them out and say, the hell with you.
Right. Well, and you understand the nature of the disease, but at the same time, I mean, it just sounds like you're really straight with people. Like, here's the way this clinic works. I have solutions for you. If you want to engage with me, I will engage with you, and this should work for you.
Yeah.
If you don't, though, then take your time, figure it out, and if you want to come back, the door's open.
We're here to help. That's all I can say. We're here to help. And you mentioned the monetary thing, which I'd love to get into. We have colleagues in the area that accept cash only. And I believe the reason they do that, and this is not to be disingenuous, but, is they don't want to be caught, because insurance companies monitor, and their thought is, if I take cash, then the odds of someone seeing me and finding me are not good. And the problem is, it's just not so. DEA, FDA, whoever, they're looking at what we're all prescribing. They're looking at amounts. The insurance companies are. I sit on Centene, which is a major insurer's corporate committees here in Indiana on the quality assurance, and I am the addictionology representative for Indiana for that company. And we're looking and we're seeing. Now, the issue that I have is that insurance companies and insurers are still paying for MT. And my cry has been, why are we not looking at those that are getting Suboxone or the dreaded M and then saying you're getting a charge for the M or the Suboxone? Is this same patient incurring a charge for mental health? If not, why not?
So here's a question I have for you. Why do people just do MT by your estimation? Because I think a lot of us in the community agree that you have to provide psychosocial support. That's like one leg of the stool. You got to get all three of them. Why don't people do it?
Because I have the luxury of having created a multi-specialty group where my initial concern was, if I'm doing this, I'm doing it right, and I'm going to have the mental health on board. These people don't. And again, going to arguably our next topic with expanding the X waiver, I have huge concerns, and I know that there's people who think it's great. My issue is that giving someone a license to prescribe opioids for just a different purpose is all that it's going to be. If you don't know a mental health counselor, if you don't have their phone number in your Rolodex, to use an old word here, you're not going to recommend it. Or worse, you're going to say to the patient, we do MAT, except here we do the M part. You need to go find your own A. And we all know these addicts are not going to go find the A. It's hard enough to get them to go to AANAHA, pot A meetings, what have you, as it is. So expecting a client to go seek out their own mental health is just ridiculous, and yet that's what happens. So to answer the question, the problem is that all doctors know is M. I'm a physician, I prescribe, and I'm trained, dear God, to use that word profanely, trained in addiction. So I'm going to take care of your Suboxone, and the angel of God will come down and tell us where to send you for mental health, and maybe we'll find a psychiatrist, and it never happens. It never happens. I mean, I quote a statistic, but I would tell you 95 to 97% outpatient, not inpatient, outpatient programs do not have mental health. And if there's people listening, please chime in and let me know if you've got part of the A either in-house or you immediately access the A, because it's not happening in my area.
Yeah. And please, that's a great reminder for viewers. Please feel free to comment if you'd like to ask questions or to add to the conversation. But yeah, what that speaks to, in my mind, also is this question of integrated care,
Correct.
Which is something we've heard a lot over the past 5 to 10 years for any population, not just addiction. What we find is that people, like if they go to their primary care physician for any mental health concern, any behavioral health concern, the chances that they actually get to another specialist, if it's not co-located in the office, it drops off. Yeah, it drops off considerably. But then imagine that you're dealing with addiction, right? With all the chaos that comes into your life. I mean, you want to be able to provide it all in one place, but it's tricky.
Right.
And so you mentioned the X waiver, and that was what we want to talk about next. So for the listeners who are not aware, so the X waiver is what you need to get in order to prescribe buprenorphine for addiction. And it's not super hard to get. It's like, I think 8 hours of CME, and it's very doable.
Good education.
Yeah, it's just a little bit of education, but there's a barrier there. You have to get the education first. And so the people who are critical of that say, we need more people prescribing bupe because we're in the middle of the opioid epidemic. So let's take down that wall, that education wall, and just let a lot of people do it. For a second there, that happened actually right towards the end of the Trump administration. Then the Biden administration rolled it back to reevaluate. And there's a bit of a debate going on about whether or not it should be there. So Dr. Miller, it sounds like you're very firmly in the camp that people should be educated about this before they prescribe.
Absolutely. And that's the biggest issue. I mean, it's just another drug because you're allowed to prescribe Suboxone. Interestingly, you don't need an X waiver to prescribe buprenorphine or Suboxone, which is just buprenorphine with naltrexone. You don't need an X waiver to prescribe that for pain.
That's right. For
pain, it's open. As soon as you use that ICD-10 code, opioid addiction, now you need the 8 hours and the X waiver, which again, first year you can treat 30 a month, second year 100, third year you apply and you're given a waiver for 275, which I don't think anybody ever achieves, which is great. But again, the problem is that it's just another pill. We've already seen that doctors that have the X waiver and gained it through the 8 hours training completely forgot the training. These people are given one Suboxone a day. They're not. It's as though you're reading a comic book on addiction. You read it. It was a fun story. And now I can get on with my life. There's not a problem in my mind. And I keep hearing this. there's not a problem with access. I believe that access is not the problem. And going back to the old thing about, why are they doing this for cash? There's no competition in the addiction field. There are so many addicts that we will be employed for the rest of our lives and beyond. When one leaves, there are 10 to take its place. So you can't possibly look at it as a competitive practice where if the addiction center opens up next door, you've lost your patients. Not going to happen. But the problem is that if you're not doing it right, then you're just pushing pills. And that's already the majority of what's going on is MT. And my fear is that when you open up the X waiver and get rid of it, you're just going to have more MT because addicts are looking for easy access to drugs, and adding more people to give them buprenorphine legitimizes drug pushing. No question about it. We're taking it from the oxycodones all the way. Now we're going to be just using buprenorphine as the substitute.
Well, it certainly reduces the barrier to entry. And, when you're talking about bad players and, how
Right.
people, pill mills and things like that, there's definitely is doing more harm than good. What's interesting from my side is that I'm not sure it would make much of a difference in terms of positive gain, if only because when I look at the Chicago area, which is where I'm based out of, and even Illinois, there are so many more X-waivered providers than people who actually use them. It's not like people can't get it or that it's onerous. I even think that there's like scholarships and stipends where like a physician will be paid, I think like $1,000 to do this, right? So it's not like you can't get people, but people don't do it. And I think the reason why they don't is because it's logistically complicated, as you're saying, to do it the right way. Right. You have to have a system, you have to have spreadsheets, you have to count. I mean, there's so much you have to think about. And I think that what would be more impactful, just having lots of potentially untrained people trying to do this work, or providing more resources for people, I guess trained or not, to do it the right way. I would much rather have fewer people doing it the right way than more people doing it the wrong way.
You said it's
kind of how I.
You my words exactly with your voice. I agree. It's not here in Indiana. The state just gave out a grant because they had decided that no one should be within 1 hour's driving distance of a treatment center. And they looked at all the counties, and the state of Indiana offered a grant to entities that applied to set up addiction treatment centers in certain counties so that everyone would be within 1 hour's drive of treatment. Now, I will make a small comment on who they chose. It was laughable because they chose some of the larger institutions that have some of the worst programming. They've got fabulous grant writers and nothing beneath the grant. So that's personal axe grinding. I admit that freely. But the fact still remains it wasn't needed because there are providers. With telemedicine, we can do that. This DNA thing that we talked about previously, I can send the cup to the patient, have them fill it or specimen, FedEx it back to Genetox, and I can get their urine. Now, yes, I might have to give them 3-4 days of buprenorphine, Suboxone in the interim. That's okay. So if you lied to me, you beat me for 3-4 days of Suboxone. But if you're giving someone 30 days, no addict I know is taking 30 days worth of Suboxone and religiously taking it as ordered. They're chipping them off and they're selling them. So in terms of economics, we miss the fact that a lot of opioid addicts are on Suboxone making livings selling their Suboxone.
Right. Well, I mean, that's a whole nother issue as well. I know we weren't planning to talk too much about diversion. I mean, and we see that honestly with all sorts of opioid prescribing, Suboxone or not, where if people know when they're getting tested, for example, you can take something, get your urine where it needs to be, and then sell more of the rest of it. I mean, there's a lot to contend with, which in my mind, and we've got a comment thanking you for clarifying what's going on with the X waiver, but. In my mind, it's really about, are you doing this the right way? Because if you're not, maybe if you help 10% of people and you do nothing for 40% of people, but then you're harming 50% of people, that's not necessarily any better. And so it's all about the way everything ends up. But let's pivot for a second. I want to make sure that we have time to talk about methamphetamine, because this is an area of specialty for you. We're about half done with our time. So I guess just to set the stage here, what got you particularly interested in methamphetamine addiction? And before we even talk about treatment, I know that you've been doing a lot of talks on categorizing different types of methamphetamine addiction and how to treat them differently. So could you give us a little information about your theories here?
I can. Yeah, I've got my head. I looked, my power cord came out. My computer was threatening to kill me. So I thought, well, let's fix that.
Oh no, yeah. They'll have to vamp.
So the lights,
I'll juggle.
The issue basically was, I looked at the methamphetamine crisis and those clients that were coming in. And my first question was, why? Why would anyone want to use methamphetamine? Opioids are easy. Everything that causes pain, brains hate pain. Opioids stop pain. Anxiety causes pain. Depression is pain. PTSD is pain. When pain, you take pain pill. That's an opioid. That was a no-brainer, even for a simple thinker like me. But meth, I couldn't understand. Why would anybody knowingly take something to rev themselves up? It made no sense. We know historically that the kamikaze pilots in World War II used it. We know that the Nazis were huge users of methamphetamine. We know that in the Philippines, for example, they still use it to increase worker productivity. That's a fact. We know that in the United States it is approved for weight loss and for ADHD, and hence that topic. I said, well, the only thing I can think of where a stimulant is truly needed is in this ADHD concept, where the way I understand is children's brains need more arousal. And so by giving them this stimulant, you increase the brain's arousal, and the brain basically says to the child, I now have enough stimulation coming in from all sources. I don't need you to run, jump, scream, be defiant, kick out the chair or whatever. Very simplified, but when you're a surgeon by training, you want things easy. So that made good sense to me. But then I said, why in adults are they using it? Well, when we look at the literature, and I'm happy to let you talk about the two major thought process papers, whatever, it made no sense. As I said, my organization and I differ from anything else we've seen because we make a diagnosis. And I said, I can't just give someone a medication to treat meth without knowing why they're using meth. And that's been the missing component. And again, to turn it to you for a second, would you mind going through the two papers that you're aware of, the Contingency and the other one, if you can, on that are talking about treatment of meth?
So I'm actually not sure which papers you're referring to.
Well,
I know Contingency
Management. Right.
Yeah, well, contingency management. So contingency management, of course, has to do with providing incentives when if you're providing negative urine drug screens or completing treatment objectives. You have it's like a reward system. So the classic contingency so for those who are not aware, classic contingency management is when you have this positive outcome, you want to reinforce it, and the idea that intrinsic motivation, or rather extrinsic motivation, turns into intrinsic motivation over time. And so basically you reward people for not using their substance. Mm-hmm. And then they draw like a it's kind of like drawing out of a hat, and you get a different prize depending on what's there. And it could be small amounts, large amounts, but it's that idea of variable frequency reinforcement to help influence change. Now, what was the other method?
The other one was Naltrexone Wellbutrin. That one just came out. And I apologize for putting you on the spot. I figured I would stop talking and give you a chance too.
No. And so, honestly, so we don't see as much methamphetamine here in the Chicago area as others. So this is an area of weakness for me. I'm always happy to admit what I don't know.
Oh, I'm sorry.
So I'd love to learn from you in this area.
Yeah. Basically the second study recently came out as Naltrexone and Wellbutrin. And they said they gave them Naltrexone and Wellbutrin. And the study, and it was very surprising to read. I was kind of surprised they published it, because to put it in layman's terms, they said, well, we gave them Wellbutrin and Naltrexone. And interestingly, some of the people responded, and some of the urines that we got actually had no meth in them. And they published that. And I said, I recognize that something might be better than nothing. But when you've got a paper that says occasionally and maybe and sometimes, I'm not sure that's a very good paper. And again, the issue I have with contingency management is I use a simple layman's term for that. It's called bribery. And again, it is. And there's a whole host of issues with contingency management. One, the ethicality of bribing someone to do that. Two, ongoing costs. If you're giving someone a $25 gift certificate, every week they give you a clean urine specimen, that's $100 a month for that patient. If you got 100 patients, who's paying that bill? And their outcomes were not very, very good. And most important, I'm a physician, and I've used this word again and again, diagnosis, they're assuming that every meth user is homogeneous. There's no differences and that one size fits all. And that I have the biggest problem, because I wanted to know why. Why are you using meth? And to ignore that completely and just say, here's two pills or a pill and a shot, we're going to stop it. That makes no sense to me. And their statistics were unimpressive. It's better than nothing.
Let me jump in for just a quick second and acknowledge. So we've gotten some comments about access for those. Thank you for those comments. We're going to swing back to that. I don't want to derail us off of the meth conversation, but we will come back to your comments, those who have put those in the box. Second, I just wanted to reinforce what you were saying about diagnosis. So contingency management is a really controversial subject. And what's interesting is that while it looks like the evidence hasn't been there for meth, we've seen some more promising results with different drugs, like actually cocaine. Kind of the standard study on contingency management was on cocaine, and that one actually looked a little bit better. And there's a digital therapeutic that I like. I think I've been involved in their advisory panel called Reset, if you're familiar with that one. It's a digital therapeutic kind of based around contingency management. It's not 25 a week by any means. So it's kind of stimulating that reward in a different way, but the data works a little bit better for that. But certainly, depending on the substance, you might get very different results as well.
And something's better than nothing. I mean, because we know that, and we both have met hundreds and hundreds of opioid addicts, meth addicts, whatever, who just stopped with no treatment. So we know that one size doesn't fit all. I've got plenty of people that I'm working with now that are former heavy meth addicts, prison as long as your arm, multiple, and they're done, and they're 4 and 5 and 6 and more years sober. But my issue was why? And so what I did was I started to talk to these people. Now, interestingly, when I started to look at the scientific literature to see if there were any whys, there aren't any whys. The things that we are discovering, doing very aggressive and in-depth histories from our patients, social evaluations, interactions with others, job performance, marital history, whatever, those papers are saying what we see on meth users is inattentiveness. We see hyper-emotionality. We see hyper-focus. We see low energy levels. And then they said, that's because of the meth. And I will tell you that our evaluation shows that nothing could be farther from the truth. We are seeing those in different scenarios as predisposing factors. And we're seeing it time and again. We ask them, before you use meth, what was it like? What's happening? And when you take a good history, we are seeing it. And to kind of cut to the chase, we've successfully identified 2 major categories of methamphetamine users that differ dramatically. And if they differ dramatically, you treat them differently, but both of whom self-use meth to resolve their issue, or at least they try. It makes things worse, and that's where we differ from what's out there. I don't believe in homogeneity. We need to find out why. We make a diagnosis, we identify appropriate non-controlled treatments, and when you're ready, I'm happy to give you what, we talked about numbers before. So having introed myself.
Well, so before we get to the numbers, so you got me on the edge of my seat. What are these two? What are these 2 categories? What are the categories?
Well, and again, since no one has done this work, it was up to me to come up with them. And so basically, the 2 major categories, and I'll give it basic explanations, and we call them Cat 1, Cat 2. That's easy. Category 1 we call LISA, L-I-A, low internal state of arousal. These are people, and if you're dealing with meth users, cocaine users, spice users, any stimulant, these people have no energy. These are they're the nicest people you'd ever want to meet. But as they say in the old show, hee-haw, they're get up and go, got up and went. It's gone. They are undependable. They can't get to work. When they get to work, they can't complete. There may be a little bit of that. They jokingly say, squirrel, where they're directed. But the major component is they have no energy. They can't get started. It takes them hours to get up. They use meth in the hopes that it'll give them some energy so they can function during the day, because their brain is saying, I got nothing here. I can't get help. I can't get help.
Right. So category one is just low motivation, low energy.
Low energy.
You're using it to put some pep in their step.
Correct.
So what is the second category?
Second category we call CAP, chronic aggressive or agitated presentation. And I will tell you that is a very, very fancy term I came up with for what is unquestionably ADD. Because I have convinced, and I will argue with anyone, that ADHD cannot exist in adults. It's not possible, because adults can't have the H. I mean, you know, you and I are adults. If I asked you, are you allowed to run around the room and scream and kick and be defiant, whatever, you may want to, but you can't, because you're an adult. Your brain is different than that of a child. There's societal influences. So the H can't exist in adults, but the ADD can. And what we see in these adults, and I will tell you, Aaron, it is almost laughable how easy this is. It's embarrassing, because these patients will start talking to you. And we had one lady who was talking to me, giving me her history, and 15 seconds later suddenly went blank and said, I'm sorry, I forgot what we were talking about. She was leading the conversation, no interruptions. So the stigmata are A, loss of continuity of thought. These people can't pay attention. It destroys their interpersonal relationships, their marriages, because the wife says, why aren't you paying attention to me? And the answer is, I can't. I have ADD. Second most common is hyper-emotionality, where when you talk to these people, they will listen and everything can set them off. The slightest provocation, a phrase they don't like, or the wind blowing through the leaves is enough that they suddenly, a switch gets flicked, and they are angry or hyper-emotional, and it can happen, and it can last seconds, minutes, or hours. The bad news is that once it's over, they forget. They say, come on, let's go out for lunch. And I'm not going out for lunch with you. You just beat the heck out of me. No, I didn't. Yeah. Yes, you did. No, I didn't. Yeah, well, I didn't mean it. And they forget. Third and category is hyperfocus. You know, Michael, pay it. And like, what? I heard you. No, you didn't. It's they focus, you know, that squirrel thing, and it's the opposite. But when we do this history, these patients, and I encourage the audience, sit down and talk to them, ask them these questions. When we have these category twos, I mean, again, it's embarrassingly easy how easy this is diagnosed. These people tell you, yeah, they're always looking. You know, we had a man who said, I loved my wife more than life itself. I would die for my wife, but sometimes she pushes my buttons. And I said, time out. You just told me you love your wife more than anything else. And yet, why would someone that loves you want to actively make you angry and push your buttons? And he said, you know, you're right. I said, how about a scenario like this where you didn't load the dishwasher so well? And your wife said, honey, when you put the dishes in, would you put them facing forward? They get cleaner. And what you heard was, you are the worst husband in the world. You don't even know how to load a dishwasher correctly. I don't know how I married you because you're a moron. And this guy looked at me and started to cry and said, you know what? You're exactly right. That's what happens. And we hear this again and again. So asking this history, taking the history. And again, it's like Moses parting the waters, my friend. These people move to one side or the other. And if they're primary meth users, this is what we've been doing. And we have been hugely successful in mitigating cravings. In 72 hours, I can shut off cravings for methamphetamine.
All right. Well, we will get to that in just a second. And I'd love to hear about how these two categories are treated differently. I mean, so it sounds like first category is kind of lethargic. Second category is essentially attention deficit disorder or ADHD. And I know what you mean about the differing presentation of the hyperactive element potentially of ADHD. And I agree. I think I've seen very few patients who really exhibit like psychomotor agitation, you know, is what we usually put in our mental status exams when we write about it. I think it oftentimes comes out more if they were like that when they were younger as this really internal pressure.
Correct.
And, you know, certainly, you know, but the inattentiveness, absolutely. I mean, I've heard plenty of stories of that. There's books been written on like how do you work with, you know, husbands or wives who have ADHD. Mariana left us a comment. She's a pharmacist about how absolutely there are still large doses that she sees going out to adults. And it's true, ADHD doesn't just disappear as people get older, but it sometimes, it does sometimes actually, but it certainly can change its form. But you said that So you've got these two subtypes. Diagnosis is important. So how do you treat them differently? What does this look like?
Well, one, and with respect to that thing, there is no way in heck that I'm giving any adult an amphetamine. In fact, I would tell you it is the worst thing. My colleagues, my NPs that are psychiatric trained are told up front, under no circumstances will I, as medical director, tolerate an amphetamine for any adult under any circumstances, because there's no need. The problem is that these adults remember when they were 8 years old on Ritalin, on Concerta, on methylphenidate, and their brains say, oh, I remember that helped. Why don't we get that? And then they talk to the local family doc and they say, well, it worked when I was 8. And the family doc, sure, what the heck? Here you go. And the comment popped up, the audience to see it, has patients getting 5 of these pills a day. So I would tell you, if you got people on stimulants, you're being disingenuous, you're being unprofessional, unethical. I'll use more adjectives as long. Stop the amphetamines. There's no reason. They don't have the H. And the way we so the treatments, to answer the question, having said I will not give an amphetamine, we still need, in category 1, the low internal state of arousal, we still need to increase their arousal. And I don't like to use the word energy. I like arousal. And so we use 2 medications. Medication 1, they go on modafinil, also called Provigil. Provigil is a medicine used for narcolepsy, shift worker syndrome, multiple sclerosis. It is a medication that is a non-stimulant stimulant. They get 100 milligrams twice a day to start if they're diagnosed with category 1. The second medicine we used, interestingly, is Remaron. Remaron is a medication that also increases arousal. And in fact, we're starting to use more Remaron even in non, because what we find is we're starting to hear a lot of complaints where patients will say, I can't sleep. And I say, why not? And the 2 lines we hear is either my brain won't shut off or my brain won't stop running. And to kind of digress for a second, what I explain to them is it's like shutting off your laptop. When you shut off your laptop, you don't hit the button down. You boot it down so it can store all the things you've been doing in preparation for the next time. When you go to sleep at night, your brain goes through these phases and it has to process your day's activity, but that takes energy. If you don't have enough energy to do that, or God forbid you give them a sleeper like trazodone or Ambien, you are reducing the brain's energy, and the brain is not able to shut all that off and solve all those problems. So they may get to sleep, but they wake back up. So we give Remaron, or if there's an issue with the Remaron, we use Wellbutrin twice a day. We have patients that sleep 10 to 12 hours on the Remeron.
So,
they say, oh my God.
So quick question about the Remeron is that mirtazapine? Is that the same thing? Is that, so I thought that it was. I thought that mirtazapine low dose was a sleep aid. Is it actually? It
is, because it increases internal brain arousal, and it is. It's the funniest. It's paradoxical, and it works when we hear that. My brain won't shut off. Remeron, 15 milligrams at bedtime, and watch him sleep. It's unbelievable.
So I want to hear more about the numbers too, because we're getting close to the end of our hour. But just to be clear, so what you're doing right now, these are off-label. That's working, but it's off-label at this point.
Yeah, as a licensed physician, I have the right and the privilege to use medications as I deem appropriate. And again, having made diagnoses, and again, the CAT ones, the LISAs, low internal state of arousals. This isn't me as a former general surgeon. I talked to psychiatrists. I talked to board-certified sleep medicine docs and went to them and said, here's what I'm looking at. What are your thoughts? So this wasn't created in a vacuum. This was created with lots of input from some very astute clinicians who said, here's what I think will help. And again, the second, the category 2, the CAP, chronic aggressive, that's ADD. When you look up ADD, there's 2 medicines after the equal sign. One is atomoxetine, Strattera, and the other one is guanfacine. So depending on weight, they go either on 40, 60, or 80 of Strattera in the morning. And then I add 1 milligram of guanfacine in the morning. And I tell these people, and I will hit the numbers, that in 72 hours, I will shut off your cravings for meth, and you will have improvement in the inability to focus, the loss of continuity of thought, and the hyper-emotionality.
So what I think is fascinating about what you're saying is that you're really bridging the gap here between psychological functioning, and then you're saying, well, let's go to the root of why you're using meth in the first place, and let's try to treat that. as opposed to necessarily just working on the particular chemical systems involved in meth. And what you're finding is that that's actually been really effective. You've got two different subgroups of meth users, and that if you treat them appropriately and you get at the core reason for use, you can have a huge effect in reducing cravings.
Correct. Right. Homogeneity is a 4-letter word to me.
Well, so hit us with those numbers. What have you found in your work?
I want to make it clear. We are right now under an IRB for review of our work with Remaron University, which is here in Indianapolis. I have the pleasure of being an assistant professor on their faculty. Very dear colleagues of mine that are PhDs are crunching our data. So I'm not at liberty to reveal the long-term data, but to cut to the chase, at the present time, all comers over the last 2 years with 63, I'm going to put my glass on, with 63 patients enrolled and diagnosed, and these are Cat 1 and Cat 2. We didn't break them out. We will for the study. 53 patients were identified as having received the medications, because that's the biggest thing. They don't pick them up. They only use one of them, whatever. We have identified patients who, after diagnosis 1 or 2, got both medications and initiated them, that at 72 hours, which is the numbers I'm using, at 72 hours, no meth in their urine and no subjective reports of cravings, 84.1%. So I am now saying that at least preliminary, I can shut off cravings for methamphetamine at 72 hours in 84% of the subjects that we evaluate, diagnose, and treat. And what that means is that they are now able to participate in the A part of MAT without spending their brains searching for their next fix. That was my initial goal.
Yeah, well, and that is hugely promising results, in the early going. Like, this is 84% for something like addiction in terms of, and I know it's early, you're looking at the long-term data, but, obviously right now, anecdotally, you're looking at what you're doing and you're not finding that everyone's just crashing and burning it like or something. No. And so I'll be really interested to see. And I know what excited me when we connected about this was that this is where new techniques come from, right? Is that you've got someone trying something new, looking at it with a different theoretical lens, and then actually finding results that you then push out, and then other people do it and they push out results, and then eventually we might actually have a widely accepted map for methamphetamine, which right now we don't, which would be amazing to help so many lives.
Right. And as you said early on, now that I have at least some preliminary numbers, and this is the first time these numbers are being publicly presented. I got this morning because I threatened my nurse, by the way. Said, I'm going to be in with Dr. Weiner. I need this. But, the initial response has been, if there's something less than lukewarm, it has. We actually wrote a preliminary paper that I wanted to get feedback on. And the title involved the word paradigm shift, a new paradigm shift for consideration of etiologies of methamphetamine use. And we sent it in, and they didn't even look at the paper, and the editor sent it back with comments. We already have a paper reviewing meth. And yes, your face was the same face I made. And they didn't. The second submission they sent it back and said, you need to provide your own reviewers. And I thought that was strange because, I review for a major international wound care journal, JWC, out of Europe. I'm an independent reviewer. Finding my own reviewers seemed very, very problematic to me.
Yeah, that seems like, unethical.
And the third one we sent it to, interestingly, they looked at it, and one of the reviewers must have done a brief review and sent it back and said, I'm not sure this is going to work. Send it back to them. And we didn't have numbers. I was just propounding the theories of how we evaluate Cat 1s and Cat 2s. And I thought, looking at a different way to it now, it never even got past the reviewer. They didn't even make comments. They looked at it and said, we're not sure this is going to work, and sent it back.
Yeah, well, data speaks volumes. And so I love the fact that you have some preliminary results today. I would love to hear more as this goes along. What I want to do really quickly, though, we are almost out of time. I just wanted to highlight, so earlier on, there were a couple of comments. I'm going to throw them up on screen here. For just talking about how the people actually are in some states, like this gentleman from Kentucky, or woman, actually, I can't tell who it is. Their name isn't showing. And then another one here from Ohio saying that actually there are some access issues. And so I think, just something to realize, this is a national issue, but it's on a local level where we have to solve a lot of this, and it's tough to wrap our arms around. It's true, in the Chicago area, we have bunches of X-waivered physicians, many of whom aren't using them. You go to Kentucky, you go to Ohio, in certain areas, maybe it's completely different. So
Kentucky has a fabulous program called Isaiah House. Mark Lapalm, a very dear friend. They are pure abstinence. They're not opioid MAT, but fabulous outcomes. But again, not an MAT program. They go right to abstinence. Mm-hmm. Ohio, I can't speak of. I don't have many colleagues in Ohio that I communicate with. But I recognize it's a problem of disproportionate placement of providers. It's there.
Absolutely. Well, so we are very nearly out of time. Dr. Miller, do you have any parting thoughts that you want to leave the audience with? Any take homes that you'd like them to have today?
Again, I and my organization, because of the rather unique way we're doing it, I'm thrilled to discuss with anybody. Emails, Dr. Weiner has contact. We're in Indianapolis, Miller Care Group. If you want more information on what we're doing, if you want assistance, this is not rocket science. If you're a provider, this is a good history. And again, I train fourth-year medical students, and these kids, most of whom will graduate in a month, sit there with their jaws dropped and say to me, it's unbelievable how, taking good history, these people make the diagnosis for you, and they will if you're willing to sit and listen.
Yeah. Yeah, the time in medicine is like it's the balance that's always hard to work out, particularly in today's modern healthcare system. But if you can take the time, it's better on your end as a provider, and the patients feel it too. They can tell that you care. They can tell that you're putting them first. But thank you, Dr. Miller, so much for sharing your expertise and your time today. I know I learned a lot from you today about methamphetamine. Hopefully the audience did as well. Thank you, everyone who submitted questions.
Thank you.
If you'd like to follow up, reach out to me. You can reach out to Dr. Miller. He is also on LinkedIn. We would love to connect with you. For now, though, thank you so much for your time and attention today, and we'll talk to you all again soon.